Good evening, everybody. Well, we just have a few more people planning to join, so we'll give them a few more minutes to join. During the meantime, you can go have a look at the association's website, and you can see some of our upcoming events, as well as become a member so that you regularly get notified about any upcoming events. Today's talk is about Scimitar syndrome, and we have Professor Ignacio Lugones with us today, who's kindly agreed to give a talk about his way of preparing Scimitar syndrome, as well as a general overview of the pathology, and he's going to walk through it with us today.
Hi everyone, it's a pleasure to be here. Ayush, you let me know when you want to start, and I will be sharing my screen.
Perfect. I think we should just have a few more people joining. I can slowly see people logging into the screen. All right, perfect. So just before we start, I thought we'd talk a bit about the association itself. My name is Ayush. I'm one of the founding members of the society, and my role is the Surgical Skills and Simulation Secretary. So we founded this society a few months ago because a lot of us who had similar ideas of wanting to pursue a career in congenital heart surgery wanted to have a community that we can learn about congenital heart surgery and actually walk through it step by step and interact with people who are deep diving in the specialty itself. So these are the members of our team, some of whom you might be familiar with. Some of the people weren't able to join us today, sadly, due to work commitments. However, we plan to have them along for future talks as well and any in-person events we have. This is the talk today, an overview of Scimitar syndrome and techniques for repair with Professor Ignacio Lugones. And stay tuned for upcoming webinars. Our next two webinars are going to be looking at AVSD repair, as well as approaching both atrial septal defects and ventricular septal defects separately. And these are some of the other upcoming webinars that should be coming in a few months' time as well. An in-person event will be coming soon. We're planning to host a wet lab locally in the UK soon. And stay tuned to our website and social media, including LinkedIn, Instagram, Facebook, and Twitter, to keep updated with any future events. And become a member to our website. So without further ado, I'd like to introduce Professor Ignacio Lugones. I think you're on mute, Ignacio.
Well, thanks everyone. Well, thank you very much, Ayush. It's a pleasure to be here. I will start sharing my screen right now.
Thank you so much. And we're looking forward to have a brilliant talk for you today. And just to remind you, you can ask your questions in the chat as well as in the Q&A, and we'll try to get through them as we go and have a discussion time at the end as well. Thank you.
Well, can I start?
Yes, please go ahead.
Okay. Well, it's a pleasure to be here. Thank you for your kind presentation. Ayush, my name is Ignacio Lugones. I'm a congenital heart surgeon. I am the head of the unit of cardiac surgery in the Children's Hospital of Buenos Aires, Dr. Pedro de Lizalde. And I will be talking about an overview of Scimitar syndrome and techniques for repair. I know that the audience is a bit, there is a wide variety of levels of training. So I will start by the beginning, but before I start, I would like to mention and talk a bit about the Aspiring Congenital Heart Surgeons Association. I think really this is an amazing endeavor. I congratulate you all for this. As you know, it's an association which is dedicated to fostering the next generation of experts in congenital heart surgery. You are the ones that in a few years will be leading the field. So I think it's very, very important for you to have this kind of these environments to discuss, to talk, to to think about the future, because the field is changing really very fast, and there are a lot of challenges coming, especially for us as cardiac surgeons. And the role of percutaneous treatments is every day is being more important, is becoming important. So I think we need to adapt to this new world and think in creative ways to make our work really still valuable. So this the mission of this association is to provide supportive and educational environment where aspiring surgeons can thrive, learn, and connect with leaders in the field, and especially between you. So I will start by defining Scimitar syndrome. The definition is, let's say, very simple. I will simply read it because I don't want to forget anything. But Scimitar syndrome is a rare congenital heart defect characterized by malformations of the vascular, bronchial, and parenchymal structures of the right lung, consisting in partial or total anomalous pulmonary venous return to the post-hepatic supradiaphragmatic or infradiaphragmatic IVC associated with malformations of the right lung, parenchyma, such as hypoplasia, or usually associated dextrocardia or mesocardia, and anomalous collateral vessels that come from the inferior, from the abdominal aorta and go to the right lung. These vessels are almost the rule, and especially those vessels that are born in the proximities of the celiac trunk. So it is very important to keep that in mind. You need to go and look for them and eventually close them if the patient is symptomatic. And of course, there are many times in which this defect is accompanied by an atrial septal defect. As you might know, there are two general types of presentation. You have the infantile presentation, in which there is a patient that is a newborn or less than 1 year that is in severe heart failure. And usually what we find is that the patient has severe hypoplasia of the right lung and severe dextroposition and dextrorotation of the heart. On the other hand, on the other end, you can find patients which are usually asymptomatic and probably go undiagnosed during several decades, and they have only as they can remember frequent respiratory infections during childhood and during early adulthood. And when you do a chest X-ray, you find that there is a mild to moderate hypoplasia of the right lung and usually meso or dextrocardia. The Scimitar sign, by which this syndrome has been named, sometimes you can see it, and some other times you cannot see it. So don't wait to see the Scimitar syndrome, the Scimitar sign, let's say, the sword in the right lung, to establish the diagnosis. You just simply need to suspect this syndrome when you find a patient with heart failure and dextro or mesocardia. You usually have to think of this. At least you have to rule out this chance. You will see a couple of images here of chest X-rays typical from this. You can see in the infantile presentation there, you can see the coils that probably closed the collateral vessels. And then you can see other morphologies with mesocardia or dextrocardia in the right, for example, like that. There you can see in the picture in the right, you can see the Scimitar vein, very, very large one, going through the diaphragm. So to establish the diagnosis of this entity, first you have to go through the echocardiography. It is a good method to find it. And of course, but this disease also needs more evaluation, more detailed evaluation, especially by means of images. When you do the CT scan, you can see the absence of the right pulmonary veins entering the left atrium. That is characteristic. And when you go for images and you do the 3D reconstructions, you can see exactly where the Scimitar vein enters in the IVC. Of course, the cardiac catheterization is key in these cases for several reasons, not only for diagnostic reasons, but also for interventional reasons. And why is that? Because if you inject contrast in the right pulmonary artery, you will find that the pulmonary venous return, the right pulmonary venous return, goes to the inferior vena cava. You could be able to see if this vein, the scimitar vein, is stenotic or not, which is very important. And you will see the proper location of the drainage of the scimitar vein into the IVC. So that's from the diagnostic point of view, but from the interventional point of view, remember that I told you that collateral vessels are almost a rule, and they are usually born in the proximities of the celiac trunk. So maybe you cannot see them in the echo, or maybe you miss them while you do the CT. But you will, if you go there with your catheter and you inject contrast there, you will probably find them. Maybe they are small, but they are almost there, almost all the time there, everywhere, every time. So it's important to go and look for them, because these are usually the vessels that are responsible for a lot of the symptoms. Okay, so regarding treatment, you treat these patients with as usually with diuretics, and you have to go, as I told you before, to try to close the collateral vessels in the cath lab. If the patient is symptomatic, usually these patients improve a lot by closing these vessels. But then you have to go to correct the defect surgically. There has been a lot of debate, and I will tell you why. The reason for that is the reason for not every patient with scimitar syndrome being sent to surgery is that the classical approaches to this entity have failed, and have systematically failed with a high incidence of obstruction in the reconstructed pathway. But anyway, the patient should be corrected surgically. There are two main causes by which in the reasoning behind sending a patient to surgery. First, some patients suffer from pulmonary overflow, and that is no good. So it is good to reconnect the pulmonary venous return to the left atrium. But some others that, as usually in the adult presentation, do not present severe degrees of pulmonary overflow, sometimes mild or even moderate, but it is usually because they tend to have a mild obstruction of the drainage of the scimitar vein into the IVC. So there is kind of a pulmonary vein stenosis that causes these patients to increase the pulmonary pressure. So you have to send them anyway to surgery to correct the defect. It's no good to have these patients living with this disease without correction. As I told you, the two main approaches, classical approaches to this entity, are the intracardiac baffling, as you can see in the image, the first image, by which what you do is you create a tunnel from the orifice of the scimitar vein to an ASD that can be new, or can be already existing, or you can create it. So imagine that this pathway, what you do is you create an angle of 180 degrees, and blood has to come and turn abruptly to go into the left atrium. So this long and narrow path usually tends to get obstructed. And also the other technique that has been one of the classical approaches to these entities are the reimplantation techniques, with or without graft interposition. These techniques, although they might seem better than doing the intracardiac baffling, usually tend to have the same incidence of postoperative obstruction. Why? Because you move the vein and you kink it. Remember, it's very low pressure in those areas. So if you put traction on them, especially if you interpose a graft with all the complications related to thrombosis. So These techniques have shown a high incidence of pathway obstruction that has gone to 50 up to 50%, as reported in the first case, which is the largest single center study, and in a European multi-center study going up to 25%. It's important to highlight that there is no significant difference in between the two approaches. Okay. So to deal with this, in 2014, we published a new approach to Scimitar syndrome. It is not a new approach anymore because the first patient we operated on was in 2012. So far, the patient is 12 years after the procedure and is doing very well. And in this strategy, what we establish is a way to reconstruct, to make a pathway, a very large pathway, using the autologous and the inside of pericardium. How are the steps of this procedure? Well, first you can go through a median sternotomy. I will tell you a bit more about this, but you could eventually go through a right thoracotomy. But if you go through a median sternotomy, you will have to open the right pleural space very widely, and then you dissect the scimitar vein and you transect it at the level of the diaphragm. After you transect it, you have to open it longitudinally. What we want is to make a big hole on the lateral aspect of the vein in order to be able to suture it to a large incision which is made in the pericardium. Okay, so we made a wide anastomosis between the incision in the lateral aspect of the vein and the pericardium. Okay, so there you can see the scimitar vein draining inside the pericardial sac. Then we cannulate the patient in the Stardom fashion with aortic and bicaval cannulation. You do not need to go too low into the IVC because you will be doing nothing inside the IVC. So it is standard bicaval aortic cannulation, and then you go to mild or moderate hypothermia, and then the aorta is cross-clamped. What we do is we open a large vertical left atriotomy, okay? And then in order to avoid potential bleeding in the posterior aspect of the heart, we suture the posterior margin of the atriotomy to the posterior, to the pericardium that is located nearby, okay? So then what we do is we fold the pericardium over the right atrial wall, surrounding this large incision that has been made in the left atrium. In that way, what we have is, let's say, kind of a controlled bleeding. The scimitar vein lies in its native position, and the distance between the heart and the scimitar vein is reduced by means of this tunnel. Okay, the tunnel is made of living tissue. Remember that the pericardium is still nurtured with blood flow, and this native pericardium, which is alive, has the ability to grow with time. So here you will see a short video describing the procedure. As you can see, the pericardium is opened. Then the scimitar vein is transected. The distal end is sutured. Then a longitudinal incision is made, and it is sutured to the pericardium. The scimitar vein drains inside the pericardium. Then standard cannulation is performed. Aorta is cross-clamped. Then the left atrium is opened, and finally the pericardium is sutured to the outer surface of the right atrial wall, and in that way the tunnel is configured. See, here you can see a real operation gently provided by our colleagues in Madrid. There you can see the scimitar vein. They transected. As you can see, the heart is beating. They have already connected the patient to cardiopulmonary bypass, but there's no need. There you can see the phrenic nerve, which is something we need to avoid. They're looking at it all the time. And then they are suturing the vein to the pericardial sac. Then the aorta is cross-clamped. As you see, the cannulation is a standard. Then they open the left atrium. There is a wide incision which is made in the lateral aspect of the left atrium, and then the posterior margin is sutured to the pericardium in order to avoid bleeding. This step is not always necessary, but it is good to make it, because if the patient bleeds there, it is difficult to find that bleeding. And then there you can see the vein and the entrance in the left atrium. And the pericardium is sutured to the outer surface of the atrium, and the tunnel is configured. This is a very simple procedure as compared to baffling. If you try to baffle the orifice of the scimitar vein to an ASD, you have to go and do deep hypothermic circulatory arrest, find it, and construct the tunnel. Our experience is we have operated on so far 14 patients in our center with an age ranging from 2 months to 20 years. And we have the longest follow-up, which is now 12 years, 0% mortality, 0% pulmonary venous obstruction, and 0% relevant complications. Only one patient showed phrenic nerve palsy that resolved spontaneously. Although we are making an incision in the lateral, in the pericardium itself, the advantage is that we are always looking at the phrenic nerve. So it is difficult to damage it because you are looking at it all the time. And here you can see some post-operative images. Here you can see the reconstructed tunnel. You can see the scimitar vein, and all this is the tunnel that is redirecting flow to the left atrium. Here you can see an injection in the cath lab on the right pulmonary artery, and you can see that the tunnel that is made, the pulmonary venous return, is twice as large as the ascending aorta. So imagine, even if this patient if the tunnel in this patient does not grow, it is enough. It is enough for an adult. So there's no problem with this. And when you go to virtual reality, you can see how wide this tunnel is and the entrance in the left atrium. We have performed 4D flow MRI in these patients in order to evaluate the behavior of blood flow coming back from the right lung, and we saw that there is laminar flow. There is an unobstructed reconstruction with laminar flow, and that has the characteristics of a normal pulmonary venous return. That is, that blood flow enters right up to the left ventricular apex in diastole. Okay, so here you can see how you can see the left veins on the left and the repair scimitar syndrome, and you can see that the flow goes up to the apex and there is no obstruction. Okay, this is a paper that we have recently published, and it is called 11 years after the first case that we did. Which are the advantages? Well, there's a low risk of obstruction due to the absence of kinking or traction, and we build a very wide anastomosis and wide tunnel, which is made of autologous living tissue, and this is very important. The procedure is very simple and very reproducible. Okay, you do not need to do hypothermic circulatory arrest. With mild to moderate hypothermia and usual bicameral cannulation, you can do it. There's a short cardiopulmonary aortic cross-clamping times. Usually, cross-clamping times are around 40 to 50 minutes. There is no need to open the interatrial septum or the diaphragm, and there is no risk of AV block or IVC obstruction. And due to disadvantages, the technique has seen some adoption worldwide, and it has been applied not only in adults, as you see in the paper in the paper that is in the paper below, and that it has even led some people to say that this could be the optimal morphological repair for the syndrome. And some of the authors have shown how this structure grows with time. Okay. Now there is a wide variability in between patients, so I want to tell you some tips and tricks, and more. First tip: always remember the location of the phrenic nerve. Always look at it, especially when you open the lateral aspect of the pericardium. Okay, in that way you will avoid having complications. Be meticulous when suturing the posterior margin of the left atriotomy to the posterior pericardium. That is important to avoid bleeding. Okay, and as Richard Van Praag once told me, stay away from the sinus node, because if you go, when you suture the pericardium uh, to the outer surface of the right atrium, if you go too high, you can damage the sinus node or the vessels nurturing the sinus node. So always stay low, away from the sinus node. Thanks God, we didn't find any incidents of sick sinus node so far. It's important to outline that. And one trick: some cases have severe rotation of the heart, and when you find that the interatrial septum is intact, or you have a small AST, you can go for this technique that we published in 2017. As you can see, when the heart there's rotation, severe rotation, the left atrium assumes a truly leftward position. Remember that the atrium is usually a posterior structure, but in these cases, the left atrium goes really to the left. So here you can see the scimitar vein, and here you can see that there is no entrance of the right pulmonary veins into the left atrium, and that the left atrium is left when compared to the position of the right atrium. So in those cases, what you can do is what we call the atrial septum repositioning. The first part of the technique is exactly the same. What we do is we suture the scimitar vein to the pericardium. Then, when we go into when we try to open the left atrium at the bottom of the pericardial recess, what we find is that we enter the right atrium, not the left atrium. Okay, so there is no way to access the left atrium from the bottom of the recess of the pericardial recess. So what we do is we make a large vertical right atriotomy at the bottom of the pericardial recess, and then we detach the atrial septum from the posterior wall of the atria, and we suture this septum to the anterior margin of the right atriotomy. And in that way, what we do is we close the entrance to the right atrium, and at the same time, we leave a large opening on the left atrium. Okay, so that's what we call atrial septum repositioning, because we are shifting the atrium to the right. Okay, moving it to the right. So here you can see that the suture is the suture between the anterior part, the interatrial septum, and the anterior part of the atriotomy, and that you can see that the left atrium is widely opening. With an asterisk, you can see the scimitar vein draining inside the pericardium. And then the procedure is finished in the usual way. There is another option. You can find what I call the second trick, which is the modified Lugones procedure for cases with severe rotation of the heart and a large AST. And this can also be applicable to any case. This idea has been conceived by Antonio González Calle, which is from Seville. The first step of the procedure is exactly the same. Okay, you suture the vein to the pericardium. Then what you do is you make an atriotomy, a right atriotomy, shaped like an inverted T, okay? So then the posterior remnant of the interatrial septum is is opened or resected, okay? So you build a wide connection between the pericardial sac and both atria, okay? And the posterior margin is then sutured to the posterior pericardium. Then two incisions, as you can see here with the dotted lines, are made in the pericardium, okay? And these two incisions create a flap of pericardium that contains the vein that has already been sutured to the pericardium. So these two incisions make a flap, and the flap is attached to the margins of the atrial septum. In that way, what you do is you create a new, let's say, new chamber. Part of the interatrial septum is built with the pericardium, with this flap of pericardium, and then simply the procedure is ended in the usual fashion, closing the right atrium and closing and suturing the outer surface of the right atrium to the anterior part of the tunnel. Here you can see the result. It's a very good result in which there is a wide connection between the pulmonary veins and the left atrium. As I told you at the beginning, there is a way to do this procedure through a right axillary thoracotomy. And this is very important because minimal invasive approaches sometimes face some resistance from surgeons, because the only, let's say, argument to do so is that you have a cosmetically superior approach. But in these cases, this is not true. We can have a much better access, as you can see in this video, because the scimitar vein, the scimitar syndrome, in scimitar syndrome, the heart is located to the right, okay? And there's hypoplasia of the right lung. So as all structures are displaced, you can have better access to this to the area where you will be working. So it is very interesting to do this procedure. I haven't done it myself, but there's a lot of people that is trying to do so, and of course it has been published and all the steps have been well described. As you can see here, the phrenic nerve can easily be seen, and you can dissect the scimitar vein and suture it to the pericardium. There you can see the phrenic nerve, the vein, the pericardium is opened, and then after the pericardium is opened, the window in the pericardium is created, and the vein is transected and sutured to the pericardial sac. There you can see the vein. Oops, I don't know what happened. Sorry. Okay. Then the vein, as you can see, is sutured to the incision that is made in the pericardium. Then the patient is connected to cardiopulmonary bypass, and the left atriotomy is performed. And after that, the pericardium is folded over the right atrium. There you can see the reconstruction, the vein sutured to the pericardium and the pericardium sutured to the outer surface. And you can see that it is very cosmetically is a very superior approach. Well, I think that's all. It's been a pleasure to be here. You can text me, you can write me an email. Feel free to connect me by any means.
Perfect. Thank you so much, Ignacio. If anyone has any questions, feel free to put it in the chat. We did have a few questions on one of the email chains, actually. Someone had asked, What type of thought process do you go through when considering creating a procedure like this?
What? Sorry. What type of?
What type of thought process do you go through when trying to create a procedure like this?
What do you mean by fob? Uh,
Like, how did you go about actually creating this procedure?
oh, oh, sorry. Yeah. Well, um, as I always say, there are different ways of innovating. Sometimes the idea just comes and it's just a moment and you start thinking of that idea, but the development of the procedure is very short. uh, and some other times it requires a lot of thinking and a process that takes usually years. uh, in this particular case, it was simply moved by let's say by fear, because I had to operate on a patient, a 20-year-old patient, and I knew that the patient couldn't benefit from classical approaches. There was a stenosis at the level of at the entrance of the vein in the IVC, and there was a a large distance between the scimitar vein and the left atrium. So I knew anything that I did would not work. So it was one night, the night before the patient was had to be operated on. It came to my mind. I don't know if I was thinking about the sending procedure or something like that, because this procedure has some parts of other procedures. Remember, innovation is not always from zero. Um, so I started thinking of the idea. I had this idea of rerouting using the inside pericardium. And then, to be honest, I went to the patient and the family the morning after, before getting into the OR, and I told them that I what I had already said, that I was not sure if that the classical approaches would work, and I would try to stay to what was already described. I didn't want to innovate with her body, but in case that I confirmed that the classical approaches couldn't be done, I had another idea. Uh, and amazingly, the patient and the parents told me, go and do what you think is best. So that was really a proof of that was a lot to me. And we opened the chest. We found that the result of the classical approaches would not be good, and we started to trying to do the procedure. It took us 11 hours, uh, and the patient did really very well. Did really very well. Was discharged home 3 days after the procedure, and well, she's my friend now. She's a journalist, and from time to time we have a coffee and we talk. So it's a beautiful story for me, for her, and I hope that, and I'm happy that this technique can help some other surgeons when they choose to use it. Of course, it takes a lot of time for people to adopt a new operation, because um, uh, we are used to do what we always did. So it's difficult to try to do something which is new. Uh, but now it is not new. This procedure is not new anymore. It has more than 10 years. So, and I have seen progressively that it has adoption has increased all over the world, and I'm happy that so far the results have been very good. So I'm happy about to be able to contribute to this field. So that's it.
No, that was really interesting, and I think it answered the question very, very well. And no, like you said, with the setting procedure, even we were chatting about it before, that the way you go over the right atrium to suture the free wall of the pericardium is very much like the Senning procedure when you're rerouting the cable veins and the
Exactly.
pulmonary veins. Yeah.
Exactly. I don't remember if I had been reading about that, but probably it's not that the idea was exactly that night. Probably I was thinking in the background about that.
Mm.
Uh,
Yeah.
but I focus on the image, and I remember to be seeing the CT scan and looking at the distance between the vein and the heart.
Mm.
And I said, how will I suture this? I couldn't make the baffle because there was obstruction.
Mm.
It wouldn't solve the problem. There was stenosis. So I said the only thing that I can do is reimplantation. But
Mm.
how the hell will I reimplant this? And how will I pull from the vein to get to the left atrium? And I said, no way I will use a graft. No way. No,
Mm.
I will never do that, because to do that, I prefer to leave the patient how she is.
Mm.
So I thought that the only way to connect them was pericardium. And then, okay, the tunnel is made of pericardium. Okay, why do I need to build a tunnel, a roll, let's say? Why do I need to make a tube? Why just simply not use the posterior part? The tunnel is already made. So simply, let's build a tube with a sac. So that was more or less the rationale behind it.
Oh, thank you so much. We have a few more questions, if that's okay.
Yes, of course.
In a case where the predisposing cause is dextrorotation of the heart, do you do both the surgeries together, or do you stage the patient with different procedures?
If there is another malformation of the heart, you
Yeah, I
mean?
think in this case they said dextrorotation of the heart specifically.
Yeah, no. It's just the same procedure. Just the
Oh,
same procedure. If there is
mm,
only Scimitar syndrome, there is no. The Scimitar syndrome can come with other diseases, and the tradition of
mm,
Fallot, several others. Okay,
mm,
in that sense, if there are some other diseases, the sequence or the timing can be modified by the presence of the other disease. But if we are talking just about Scimitar syndrome, yes, I will go in one stage to do everything,
mm.
uh, either through median sternotomy or through right thoracotomy. Okay, yeah, it's one single stage.
And another question is, in a patient with scimitar syndrome who you've decided you need to perform surgery on, what factors would make you favor a different technique compared to your technique? How do you decide between when to do both?
It's a very good question. First, I have two things to say about this. First is that I think that, as I told before, the reasons for not operating on a patient with Scimitar syndrome were always bad results of the operation. Okay, if we have an operation, an option now, as we have now, that in which the incidence of complications is very low, why should we keep on not sending the patients to surgery? So patients should be submitted to surgery. Some patients, it's tricky because some patients do not suffer from pulmonary overflow. So you find them and they might be asymptomatic or oligosymptomatic. But those patients, the reason for them to be stable is because they have a balance between pulmonary overflow and stenosis. Okay. So those patients, even if they are doing fine, they are developing pulmonary hypertension, which is one of the main causes of complications in the long term for those patients not presenting early. So the indications for surgery, if we now have an approach which is safe, should be reconsidered. So that's my opinion. Okay. First is that, and second, if you ask me uh, which technique to choose, of course we haven't so far published our experience we are on our way to do so, our multi-institutional experience to show the results of this operation in large cohort of patients. Of course, if it is not published, of course you cannot know from the literature. Okay. But me, that I know the results of the patients worldwide, I can tell you that modestly I wouldn't choose another not the reimplantation nor the baffling. I would choose this strategy, to be honest. It's not, doesn't sound good to say that I say that, but I really think it, because in the literature it's very clearly described that baffling and reimplantation are not good. They have in, amazingly high incidence of obstruction. So we shouldn't be doing them anymore, nowhere. Okay, it's just simply, this is the fact. You go everywhere, you look in the literature, you see the reports, and the incidence is very high. There's no doubt about that. Okay, we need still to demonstrate that this procedure in the long term has better results. Well, yes, of course, we need to publish that, and we will publish that. But so far, I don't see a reason to still be performing the rerouting or the reimplantation.
Perfect. And someone else asked a question. Could this technique be applied to patients undergoing TAPVC repair? I think something similar to the sutureless technique, or
It's a very interesting question, and I think that yes, but the answer is probably that it is not this technique being applied to pulmonary vein stenosis. It is that this technique is the sutureless technique. We haven't innovated in that sense. The sutureless technique, in fact, uh, uh, well, I thought of the sutureless technique at some point when I was creating this. The Zenning, the sutureless technique, it's a combination of other techniques, because uh, when you treat those patients for pulmonary vein stenosis, you just simply open the veins. You do not need to suture them to the pericardium, because they are already attached, let's say. But the concept is exactly the same. We use the native sac of the pericardium to reroute the veins to the left atrium, and that's it. So I would say that the opposite. It is not this technique being applied to TAPVC. It's our technique was inspired in the sutureless technique.
okay, it's very interesting. I don't know if there's any more questions. If anyone has any questions, either put it in the chat, or if anyone from the committee have any questions as well, can ask questions directly. No, I think it looks like we don't have many questions left. It was a really good talk, actually. It went through
Well,
everything very structured, and it was very interesting to see the thought process that went behind the procedure, and also how you approach different challenges, complications, and the different approaches, how people have put their own spin on it as well. And it was nice to see the video as well, where something
yeah,
that you don't get to see a lot,
right.
the operative footage.
Yeah, I tried to make it. I had some a friend doing it, because it was mm, mm, easier to follow. The steps were easier
Yeah,
to follow. So I think it's.
yeah.
I hope you like. I'm glad that you liked it.
Thank you so much. If there's not any more questions, it'd be great if everyone could fill out the feedback form. It should be in the chat. And thank you so much, Prof. Lugones, for presenting for us today. It was a truly inspiring talk as well. And I can speak for all of us that we learned a lot.
Thank you very much. It's a pleasure to be here. Count me in for any other activity. Yeah, I sent you my phone number or my email. Feel free to reach me and ask me whatever you want. I'm open to questions and comments.
Perfect. Thank you so much.
Thank you very much.
So we'll stop
Bye
the
bye.
broadcast now and we'll just